Hello class, welcome. Today we are going to cover chapter 35 titled Leg Pain in Henningsen second edition, and we will start on page 422. So when you read this introduction of leg pain, it says this chapter describes a variety of leg pain, especially causes that are venous disease related. So leg pain is very vague. When we say someone is having leg pain, it could be a tendon issue, a muscle issue, a bone issue, arterial issue, venous issue. But so it's very broad, just saying leg pain. Anything can cause leg pain. But the chapter mainly focuses on venous related issues. And then it says protocols will vary depending on whether these examinations are performed in a radiology-based sonography department versus a dedicated vascular lab. So a radiology-based sonography department is an ultrasound department that just does ultrasound. So it may do all kinds of ultrasound, not just vascular, right? It might do in one of those facilities, may be doing OBGYN, vascular, abdomen, small parts and so on, or one that is dedicated just to scanning vascular. So those are typically, we refer to them as vascular techs because that's all they scan. And then a brief explanation of the normal anatomy will be included, but the focus is on pathology and the diseases that lead to leg pain. And it just says that B mode and Doppler evaluation in vascular labs are quite useful in diagnosis. And then bony fractures, tendinous sprains, ligamental ruptures and tears, muscle strains, tears and ruptures, nerve impingement and trauma are most common sources of lower extremity pain. So notice on that list, they're talking about bones, tendons, muscles, and nerves and trauma. Those are the most common sources of leg pain. But again, leg pain can also be vascular related, which is like venous and arterial related. Okay. On page 423, he gives us just like a quick overview of vascular anatomy. So it says that veins and arteries contain three layers. The innermost layer is the intima, which is endothelial tissue that lines the inside of the vein and then also extends inwards to form the valves. So here's a close-up view of a valve, and we can see that innermost layer, which in this case, it's like a beige color, it extends inward, which also creates what we know valves are, right? And then it says that valve can be bicuspid or have three leaflets. So that just means how, like, the valve itself, how many is there like two like this, right? Like one and two, or is there like a third coming off sometimes? And that, it doesn't really matter. They're just saying that the innermost layer, the tunica intima, is what comprises valves. And what is the purpose of valves? We should always know what the purpose of valves is. It says valves keep blood flowing in one direction. So you guys should write the word unidirectional because that's how we call it. And what direction is that, right? So we want blood going in one direction, not into what direction is it? It's always supposed to be going upward towards the heart. So when you have a vein like this, right? During systole, blood is shooting up towards the heart. So I'm going to draw the heart up here because this is the goal, right? It's going towards the heart. So during times of systole, blood is moving towards the heart. During diastole, blood actually moves away from the heart like this during diastole. And so this is a problem, right? Because now you have blood going in two directions. And so the purpose of a valve is a valve will open. So here are the valves, right? So valves stay open during systole, and that is to keep the blood moving upwards towards the heart. During diastole, when blood wants to actually go back down from where it came from, or like down towards the feet, if we're talking about the legs, right? These valves, so I'm going to draw them in green so we can see the difference. These valves will close. So they'll actually drop down like this and they'll close, forming like a wall or like a barrier. And so this blood that wants to go down towards the feet, it can't really do that because it's like being stopped by those closed valves. So then in that case, like blood just kind of like sits here for a little bit until systole happens again. And then during systole, it like shoots up again. And so this is the point of valves should close during times of diastole to prevent backflow or flow reversal and to promote unidirectional flow. Now, the muscular layer is the middle layer, and that is the tunica media. The reason the veins are much more compressible than arteries is because the tunica media is much thinner in veins. And then it says in veins because they do not vasodilate and vasoconstrict. So vasodilate is exactly what it sounds like. It's the dilation of a vessel. And vasoconstrict is exactly what it sounds like. It's the constriction or like the shrinkage of a vessel diameter. And so they're saying arteries and veins, when we look at them on ultrasound, you guys should already know now that when you see them on ultrasound, they're more pulsatile, like you kind of see them moving, like they kind of like dilate and contract a lot more than veins do. So in other words, what he's trying to convey to you in this section here is that veins will not be as pulsatile, right? Because what does pulsatility mean? It means that the vein is like getting bigger and smaller, like dilating and contracting. So veins don't really do that as much as arteries do. The lower, highlight the lower venous pressure also does not need to support the amount of pressure that the arteries need to endure. So there's also a lower venous pressure versus arterial pressure is always higher. So, high pressure blood is like blood that is like forcefully traveling through the artery. So the artery has to be like really strong to be able to contain this high pressure blood. And that's why tunica media in the artery is much thicker. The venous side doesn't really have that high pressure. And then the outer most protective layer is the tunica adventitia. Also, it says, so this is just like this first paragraph is just kind of telling us like some, really broad information about veins and arteries, like the differences between them. So number one, they're similar. They all have 3 walls. Number 2, the difference is the main difference is in the tunica media, which is not as thick in the vein as it is in the artery. Because remember, veins are low, it's considered a low pressure system with slower flow versus arterial is a high pressure system with faster flow. And then you want to know that tunica media, that middle layer, is a muscle. And that the innermost layer, the tunica intima, is what creates valves, and what the purpose of valves is to create or to promote unidirectional flow and to prevent flow reversal or backflow. Okay, so this next section is focused on the anatomy of the lower extremity venous system. And so it says, in most instances, go ahead and highlight, with a single vein, an artery is found with the same name. So if you guys were looking at veins and arteries side by side, which you guys can find pictures of that on Google, you'll see like common femoral artery, common femoral vein, superficial femoral artery, superficial femoral vein, popliteal artery, popliteal vein. And so they're saying, you'll see one vein and then it will have an artery next to it with the same name. However, there are 2 exceptions to this rule. So highlight exceptions are. What are the exceptions? And then you're going to highlight. So this next sentence is a little choppy the way he wrote it down. So we're gonna separate it. Highlight, an artery does not accompany the superficial saphenous vessels. So the superficial saphenous vessels, what is he talking about? he's talking about two. He's talking about the greater saphenous, and he's talking about the lesser or the small saphenous. So the saphenous veins are all by themselves. There is no saphenous artery. They're just saphenous veins. So if you have scanned the leg, you know that GSV stands for greater saphenous vein, and there is no greater saphenous artery. So these are singular veins here. The veins of the leg can be divided into superficial and deep. Although they are called deep veins, they are actually still superficial enough to be well visualized on most patients with a 5 to 7 megahertz linear transducer. So yes, we call them deep veins. Remember, when we say deep veins, we're talking about the veins that have arteries with them, that are paired with an arteries. So all of your deep venous system will be paired with an arterial system. But, we call them deep, but they are still superficial enough for us to be able to get to them with a 5 to 7 megahertz. Like he's saying, we don't need to use a 2 or a 3 or anything lower than a 5. Some people you can even scan with a 12 and you can still see them. They are not superficial enough, guys, for you to be able to just like look at the leg and see them, though. So they're superficial enough for us to get to them with this transducer, but they're not superficial enough for us to just look at the leg and see them. If you look at the leg and you see a vein, right, which we call varicose veins, right, or spider veins, those are not part of the deep venous system. Those are considered superficial veins, not deep veins, and they are not paired with an artery, because remember, the deep veins are paired with arteries. And then you're going to highlight the two common, so I'm just talking about this anatomy, and you can reference my picture here. The two common iliac vessels branch into the inferior vena cava. So they're talking about the common iliacs. So where are the common iliacs? These guys here. They're saying that the common iliacs, they branch into the IVC. So, you would have one on this side too, and they would come together like this, and they would form the IVC. And then it says, so I think the more appropriate word, instead of they branch into the IVC, would have been like they converge into the IVC, right? Like they come together to form the IVC, but he said they branch into the IVC. And then highlight the internal iliac veins. So the internal iliac veins are these guys right here, right? The internal iliac veins. It says they angle steeply into the pelvis, and they drain the rectum, the sigmoid, and the genitals. So those are really, really deep in your pelvis. And I know we're only looking at veins right now, but so this area right here, this is the pelvis. The leg only starts here, right? So like this would be the leg here. So if, what male or female, right, depending on what is in your pelvis, you would have like, like obviously like a bladder, a uterus, or a prostate, ovaries, and so that's what they're trying to tell you. After the internal iliacs have departed, the external iliacs proceed along the lateral wall of the pelvis. So what they're talking about here is the orientation. So you have the internal here, right? The internal was angling deep into the pelvis, and then you have the external moving more lateral, right? Along the lateral sides of the pelvis, and then eventually leaves the pelvis at the inguinal canal. So the inguinal canal is where your leg and your pelvis meet, and on this diagram, the inguinal canal would be this blue line. So that little blue line is showing you this is where your pelvis and your leg meet. And as you can see, the external iliacs do go to that level. After they pass through the inguinal ligament, the vein is called the common femoral vein. So once it crosses that point, right? So here we're calling it external, external, external. It crosses the inguinal canal, which is like your groin area, and now we're going to call it the common femoral. After about 4 centimeters, the common femoral vein is joined by the greater saphenous vein. Okay, so common femoral vein, they don't have it on this image, but the greater saphenous vein would be, coming out like this for the GSV. And remember, this is not the greater saphenous, it's a saphenous vein. And what we learned earlier is that the saphenous veins are not considered part of the deep venous system, nor are they paired with an artery. And the saphenous vein is coming from a more anterior medial direction. So I always remember the word anterior, because when you're looking at on ultrasound at the greater saph, what you're going to see, right? So here's the common femoral, and the greater saph goes like this, right? So this little upwards projection is the greater saphenous vein. And of course, it's higher, closer to the skin line. And so it's more anterior. The area where the GSV comes in contact with the common femoral vein is known as the saphofemoral junction. So this area here, where the GSV and the common fem come together, they call it the saphofemoral junction. Within a few centimeters of the saphofemoral junction, the common femoral vein branches into the femoral vein and the deep femoral vein. So where it says branches into the femoral vein, when they're saying a femoral vein, they're talking about the superficial femoral vein. I may have said this to you guys before, that there's like, most people call it SFV, which is superficial femoral vein, but some radiologists have considered this a misnomer, like a bad name for this vessel, because we're calling it superficial femoral vein, but it's part of the deep venous system. So should we really call a vessel that's part of the deep venous system, should we call it superficial, or is that weird? And so some books will just call it femoral vein. And so what they're talking about here is they're talking about this section right here, where you see the two blue vessels here, right? You have the profunda, which is like, I think I've made it confusing. This is the profunda here, right? And then this part here, this is the femoral or the superficial femoral. And so if we're going to add the GSV, don't forget to add the GSV a little bit higher than this in the near the inguinal canal, okay? The deep femoral vein, which is also called the profunda femoris, so it's this one here, and I would also write my AKAs, so deep femoral, or they call it the profunda. And then it says the femoral vein, remember, so when they just say femoral alone, they're talking about the superficial femoral. So the femoral or the superficial femoral continues along the anterior medial. So anterior, because you got to think of where we're putting the transducer when we scan someone's leg, right? So if you're scanning someone's leg, they usually have their leg like kind of like frog-legged, right? So this is their leg. You're scanning the front of the leg. That's where the word anterior comes from. But you're also scanning on the inside of the leg. So medial, right? Not lateral, because vessels travel down this path, anterior medial. And so it says the femoral vein continues along the anterior medial leg until it dives deep through the ligaments of the adductor muscles, known as the adductor hiatus or Hunter's canal. So in your leg, as you approach the knee, there's this opening in the muscle. Okay, so if you guys haven't seen Hunter's canal, you guys should look it up. But at about this area here, so somewhere about above the knee level will be the Hunter's canal or the adductor hiatus, or and what it is, it's like this little opening where your muscles attach to your bones, to your femoral bone. And why there's like this little hole in that part of your leg is because veins and arteries travel from like the anterior part of your leg, which is like the front, they have to go to the back, right? So front to back, because if you think about it, where's your popliteal vein? Your popliteal vein is in the back of your knee. So how did the vessels move from the front of the leg to the back of the knee or the back of the leg? They have to travel through a little opening. And that opening is called the Hunter's canal. or adductor hiatus. And then once the vessels travel back through that section, they're going to reach the back of the patient's leg, which is where the popliteal will be. So it says the popliteal vessels are located in the popliteal fossa. Now, fossa just means like a bed. It's like where a vessel is supposed to lie, like you're supposed to lie in your bed. So it's where you would expect to find a vessel. So, or find an organ or find like a piece of anatomy. So where do you expect to find the popliteal vein? In the popliteal fossa, right? Where is the popliteal fossa, or like the bed of the popliteal? In the back of the knee. From the popliteal vein moving inferiorly, so we're working our way down the leg, the sonographer should be able to visualize the tibioperoneal trunk. And so if you look down here at the bottom of my diagram, there's 3 vessels down here underneath the pop, and this is below the knee level, and we refer to this as the tibioperoneal trunk. And what you will see is you will see the anterior tibial and the posterior tibial branching into 2, and then there's a third one that's branching from the posterior tibial, which is the peroneal. So if you guys want to write this down, it would be really helpful. So this is called the tibioperoneal trunk. They also call it the trifurcation because there's 3 vessels. So he says the trifurcation consists of the anterior, the posterior tibial veins, and the peroneal veins. A couple lines down from there says the anterior tibial veins highlight that they are passing laterally to the tibial shaft with a single artery and paired veins. So we're talking about this one here. So this one is sitting laterally to the tibial shaft. So I know it's hard to try to put like everything together, but imagine that the patient had, this is going to be bad, but imagine that the patient had a bone right here. Okay, your tibial bone, your shin, right? Everybody can reach down on their leg. And also I encourage you to do it because this is how we scan the patient. Even if we have a patient who has like severe leg swelling, if I have to scan that lower leg, I always put my fingers on their shin bone, like their tibial bone, and I push down because I'm trying to locate it. And the reason I'm trying to locate it is because it helps me figure out where the vessels are. So if I put my transducer, so I want you guys to put your hand on your tibial bone. And I know that this is like maybe silly, but I'm telling you that this will save you when you guys are out in externship if you have to scan that lower leg. And we'll talk a little bit more about that. But if you guys put your hand on your shin, right, on your tibial bone, and from that slide lateral, so slide towards the outside of your leg, not towards the inside, but towards the outside, sliding lateral. So in that lateral part of your leg will be where the anterior tibial vein will be located. And what you're going to see, how you're going to see it on the screen when you see it, you're going to see 2 arteries like this. And it's usually like a little bit more superficial. And you have one blue in the middle, which is the vein. Because he said that it's, no, he said it's a single artery and paired vein. Sorry, I did my colors opposite than what I should have done. You're going to see 2 blues and 1 red. If your colors are correct on your screen. So 2 veins, I messed up on my colors, I apologize. 2 veins and 1 artery. So again, to find it, you find that tibial bone and move laterally. Now, if you go down a little bit more, it says the peroneal vessels run deeper and more laterally with a single artery and paired veins. And the posterior tibials continue more medially and superficially down the area just posterior to the medial malleolus. So I'm going to help you guys draw a couple things to help you. And again, it's really hard on Zoom, and it's like easier when we can see, we have like a body. So that's the knee, and this is like the leg. Okay, so from the knee down. So first you would identify where the tibial bone is, right? So here's my tibial bone. So this would be medial, right? I'm going to pretend that this is the left leg, just like for reference. And this would be lateral. Okay. Now, all of these are going to be not in every single patient, but in most patients, like more so than not, you're going to see 2 veins and 1 artery, right? 2 veins and 1 artery. Above the knee, most people will have 1 vein, 1 artery. Sometimes people will have a duplication of veins, and that's fine. You'll know they have veins because you'll always see like that extra vein on the screen. So there's nothing wrong with having 2 veins and 1 artery above the knee, but it's just not very common. It's way more common to have the venous duplication happen below the knee. That happens in almost everybody. Okay, so first you're going to find that tibial bone. So even in the most swollen leg, you can usually find it. So I put my transducer in long, right on the bone. So you would, so what would my screen look like if I put my transducer right on top of the bone? I would probably have like an echogenic line at the top of my screen. That echogenic line represents like the surface of the bone, and then the whole screen would be black, right? Because my sound wave would not be able to image through the bone. So if I put my transducer here, and I usually will put a color box on. I never try to scan the lower leg without a color box because these vessels are so small. They're very, very hard to see. So you almost always need to use your color box. So I put my transducer on the bone, and I give myself a color box, and I make sure that my color box has like really high amounts of color. So like, I don't want to have crazy levels of confetti, but I do turn up my color gain to the level of like just before confetti. And I also bring my scale down like 2 or 3 notches because I'm looking for, number one, a really small vessel with really slow flow. So it's imperative that you have high levels of color gain and also a decreased scale so that your color box will pick up these veins, or else you'll be on them and your colors won't even show up on the screen because your machine doesn't register that it's scanning them. So these are you might be thinking like this isn't really important, but guys, everywhere I've worked, we did scan the lower leg if the patient had a complaint there. So I'll talk more about the scanning in a moment. I just want you guys to understand how, I'll talk about when to scan and when not to scan in a moment, but I want you guys to understand this and write this down in your pocket notebook, because for us at Northwest College, we typically only scan to the popliteal. But the protocol does go on for many facilities. And so you need to know what happens like if you work in a facility where they want you to scan the lower leg. So when you're trying to find the anterior tibial veins, you're going to put your transducer on the tibial bone in long, and you're going to give yourself a nice big color box because you don't know exactly where the vessel is going to be on the screen, and you're going to give yourself high levels of gain, so just before confetti, and you're going to bring your scale down by like 2 or 3 notches. And then with that big color box and that high gain and that low scale, you're going to scan, you're going to angle or slide off the bone, slide your transducer off the bone laterally, and then you should see the anterior tibial veins and anterior tibial arteries. And typically what they look like, again, is you'll see 1 vein, 1 artery, and 1 vein, right? Now, if you do the same thing, right, you put your transducer back on that bone and the same color box and the same gain and the same scale, and you slide off the bone medially, you are going to see the posterior tibial veins, and you're going to do the same thing. You're going to have an artery and then vein and artery. So this is going to be the PTVs, right? PTV and the PTAs, posterior tibial veins, posterior tibial arteries. And this is going to be the TV and ATPs, right? So like sometimes students have a hard time remembering this. Like, I don't remember if my PTVs are medial or lateral to the tibial. Well, if you peed on yourself right now, the pee, the urine, would travel down the inside of your leg, right? Down the medial part of your leg. And so that's where the PTV is located. So that's an easy way to remember it. So where is the peroneal, right? So we talked about ATV and PTV, but where's the peroneal? Well, the peroneal runs more towards the calf, so it's a little bit deeper in the leg. We don't scan through the calf, so like sometimes I've had students that say like, oh, so when I scan the peroneal, should I put the patient on their tummy and scan the back of their calves? No. You would be scanning in the same location. So look what your book said. Your book said the peroneal vessels are deeper and they are more laterally. So it just kind of depends on everybody, but they do tend to be more lateral. So I would do the exact same thing, and I'm going to do it in red to show you guys. I would put my transducer right on that bone, right? So here's my transducer right on that bone. I would give myself a big color box. But now we know the peroneal, you have to think about it. The peroneals are running deep in the calf. So you should probably increase your depth, right? So whatever depth you were using when you were scanning the ATV and PTV or whatever, give yourself more of it, because the peroneals are deeper, because remember, they're running at the back of the calf. And then again, you can slide off of the bone lateral. And what you're going to end up seeing on the screen is you're going to see one set of vessels up here, but remember, you gave yourself more depth. You're going to see one set of vessels down here. The bottom ones are always the peroneals. So the bottom ones are the peroneal down there. But the top set here, you have to determine what those are. So if you were sliding off the bone in a lateral direction, then these are the ATVs. So you'll get the ATV and peroneal on the same image. The peroneal will just be deeper. Sometimes students have told me like, hey, I've done that. I've put my transducer on the bone and I've slid off of the bone laterally. And I didn't see the peroneals. I only kept seeing the ATV. And then my first question is, number one, did you give yourself enough depth? Because the peroneals are pretty deep. So if you don't have enough depth, you're never going to see the peroneals. Number two, are you, remember, they're deep in the calf, so it's going to be harder for them to pick up color flow. Are you using that high gain? Are you using that low scale? And if they're like, yeah, I've done all that and I still can't see it, and I say, okay, let's go to our second option, plan B, put your transducer back on the tibial bone and now slide this way, slide medial. And if you might see a set of vessels up here and a set of vessels down here. Now, again, the deeper ones are always the peroneals, but because you were sliding medial, these top ones are going to be the PTVs. And so usually, I mean, even your book says that the peroneals are on the lateral side of the leg. So it makes sense that you would move lateral and then you would see the ATVs at the top and the peroneals. But if you've done that and that doesn't work, then go the other way, go medial. Maybe this person has a peroneal that's like a little bit deeper and more medial in the leg. So no matter what, the peroneals are always going to be the deepest vessels on the screen, but and typically they are on the lateral side, which means at the top of the screen you're going to see the ATVs, but sometimes they're on the medial side, and so at the top of the screen you'll see the PTV. And then, so again, if we read that again, it says the peroneal vessels run deep and more lateral with the single artery and paired veins, and the posterior tibials continue to move medially. So you're going medial for the posterior tibs, and superficially down the area just posterior to the medial malleolus. So the medial malleolus, if you're wondering what that is, that's a bone inside of your ankle. So if you touch your ankle right now, touch the inside of your ankle, not the outside. But if you feel both, feel your entire ankle, feel the inside of your ankle and the outside. You have like this rounded bone on both, right? So like on the outside, you have like this rounded bone. On the inside, you have this rounded bone. This inside bone always reminds me of when I was a kid and I'd be riding a bike and my foot would slide off the pedal and I'd like skin that part of my ankle on my bike and it would it would be killer. It would hurt so bad. I don't know why that's like forever an engraved thing. It must have happened to me several times for me to be still thinking about it. But anyway, these are called malleolus bones, and the one on the outside is the lateral malleolus. The one on the inside is the medial malleolus. And the medial malleolus, if you touch that part of your ankle and you touch above that, like just run your hand from that rounded bone on the inside of your ankle, which is the medial malleolus, run it up your leg. So this part of your leg that you're touching, that this inner medial part, this is where the PTV will be located. And then it says a superficial vein. So that kind of, this explanation here. So actually, guys, I'm going to pause for a second because we've just been talking about this lower leg, right? And I want you guys to put this information in your pocket notebooks because you may be the person that has to scan it. So let me tell you, if you work at a facility that only goes to the popliteal, vein when it's scanning. So when you're asked to do a lower extremity venous Doppler, lower extremity venous ultrasound, and you only have to go to the pop, you are blessed because it's really easy to go to the pop. The vessels are larger from the knee and up. Anything below the knee, the vessels are super small. Remember, they're paired, but the veins are super, super small, very hard to obtain. Almost can't even see them sometimes without using a color box. So, you know, it's very hard to scan a vessel like that. It's really easy to slide off of it. And so some labs, some places you work, they will have you scan, you know, from the common femoral vein, you know, all the way down to the bottom three, to the trifurcation, to the ATV, the PTV, and the peroneal. And they're like, look, I don't care where the patient is complaining of pain. I don't care what the patient's symptoms are. You scan the entire leg. You scan all the veins in the leg, like no matter what. And typically when we do have to scan that lower leg, we are going to do like ATV, prox, mid, and distal, and these would be like one with color and then one with pulse wave, right? So you're taking like prox with color, prox with pulse wave, mid with color, mid with pulse wave, distal with color, distal with pulse wave. We do the same thing for the PTVs, right? So you do prox, mid, and distal, the same thing, and then you do the same thing peroneals, prox, mid, and distal. So it's 2, 4, 6, 8, 10, 12, 18 extra pictures. So this would be like the rest of the protocol. But and then I worked with some doctors that have said, like, no matter whenever you're working with me, don't even ask me if I want you to scan the lower leg. You always scan the lower leg. If the patient is here for us to check the veins, we're going to check all the veins in the lab. Don't even ask me about it. Or in the leg, don't even ask me about it. I've had other doctors that have said, no, we only scan to the pop. It doesn't matter what's going on but in the lower leg, because even if there is a blood clot in the lower leg, the vessels are so small. So like if you have a blood clot in the lower leg, your clot is going to be really small and it's going to be wedged into that small vessel, right? Because the ATVs, PTVs, and peroneals are really small in diameter. They're like this, right? So if you have a clot, it's going to be really small clot and it's going to be like wedged in there, right? Like if the patient has a thrombus or a DVT. So like chances are this clot's not going to move anywhere. It's not going to go up towards the lungs. And even if it does go up towards the lungs, it's going to be so small. In the higher leg above the knee, the vessels are big. So if there is a clot, it's going to be a big clot, right? Like this is my big clot. And now if this big clot dislodges and goes up towards the lungs, it's going to cause a pulmonary emboli and the patient's going to stop breathing and the patient can pass away. So some doctors don't believe that it matters if the patient has a DVT in the lower leg because the vessels are small, because the clots are going to be small, even if they have them, and they're not going to pose like a huge threat. And so some doctors are like, oh, I don't care. Don't scan that lower leg because I don't care what's going on. And then most doctors I've worked for have said, You stop at the pop unless the patient is specifically complaining about calf pain or like lower leg pain. So again, in this case, I mean, we would always be talking to your patient, why are you here today? Oh, you have pain, or you have redness, you have swelling. How long has that been going on? Is it the whole leg, or is it a specific portion? Now, if they tell you, yeah, if they point to an area below the knee, then like it only makes sense to scan below the knee, right? Like, I mean, the patient's like literally telling you that that's where the issue is. So most doctors I've worked for have told me it's okay to stop at the pop unless the patient specifies lower leg pain. And I remember I would always kind of hope my patient didn't have lower leg pain, because it's not fun. It's not fun to scan that below the knee area. But we're going to write that in, all this stuff that I've been telling you about that lower leg, that trifurcation, the tibial-peroneal trunk. You must know your anatomy, know where to place the transducer, know which direction to slide it. What are you going to see at the top of your screen? What are you going to see at the bottom of your screen? What is the protocol if I do have to image down there? Because don't be surprised, several of you will have to do this in externship, okay? So we're going to go back to our books now. It says the superficial vein that is routinely visualized is the greater saphenous vein. It travels without an accompanying artery. It is starting near the ankle, and it continues up to its insertion into the common femoral vein. So that's pretty wild. We don't really think about that, right? Because we always see the greater saphenous like right here, right? And we just like, oh, okay, there's the greater saph. Well, actually, the greater saph travels all alone, like the lone cowboy by itself, all the way down from the ankle to from the ankle to that common fem. We just image it at the common fem, but it is not uncommon, guys. If you are scanning, right? So like I have like my paired vessels here, right? I have my artery and my vein here. So I know that these are the deep venous and arterial. This is the deep system, right? Because they're paired. And then sometimes I'll see like a vessel up here at the top, and it's all by itself, and it's pretty superficial, and it has a clot in it. Well, what do you guys think that is? It's number one, it's not paired with an artery, so it can't be part of the deep venous system. So it's part of the superficial venous system. It's the GSV. That happens often, that it's the GSV with the clot and not the deep venous system. And if you see it, right, you can't say, well, I'm here to scan the deep venous system and that's all I'm going to pay attention to. If you see a clot in the superficial, I mean, like, our job is like, it's called an incidental finding. Like, you didn't go looking for it, but you like accidentally stumbled on it. So you got to like talk about it now that you see that it has pathology. So again, it starts at the ankle and goes all the way up to its insertion at the common fem. And then highlight, connecting the superficial veins to the deep veins are small perforators. Okay, so is it an artery? Is it a vein? I don't know. I can't tell. Which seems like a little silly, right? Like, how can you not tell the difference between a vein and artery? But like, guys, it happens all the time. Not really to techs that have been scanning for a while, but it happens to students a lot. So highlight, arteries are more rounded in shape. Veins change their shape with breathing, with respiration. Veins are compressible. Veins are ovoid, so that means they're oval shaped, not rounded, not circumscribed. Arteries pulsate. Now, veins also pulsate when they're closer to the heart. So like if you scan in your neck, the jugular vein, or like your subclavian vein, those are like really close to your chest and to your heart. So those do look more pulsatile. But we're like talking about leg pain here, right? So like we're a far distance from the heart. The veins dilate with the Valsalva maneuver, or when the patient's trunk is elevated in relation to the extremity. So that means when the head is above the leg level. And the veins have the potential of being larger than arteries. So the the correct way to position your patient if possible, guys. So you don't want the bed, this is the bed that the patient's lying on, you don't want the bed to be flat. Ideally, you would want the head to be elevated to a 45-degree angle. If the head is elevated to a 45, so your patient would be laying, you know, like this with their legs down here. If the head is elevated at a 45-degree angle, you are promoting blood flow. So like, we never really want our patients to lie flat. So when you do a venous scan, you should always like tilt the patient's like head up, like pull up the top of their bed. You guys should write that in your pocket notebook. It says veins also dilate with the Valsalva maneuver. So the Valsalva maneuver is where you have the patient take a deep breath in and hold it. So when you're having the patient take a deep breath in and hold it, there is going to, all the veins in the leg actually will get bigger in size. It doesn't affect the arteries, but it does affect the veins in the leg. So you guys want to understand what the Valsalva maneuver is. So it's really just like instructing the patient to take a deep breath in and hold it and bear down like they're doing like an abdominal crunch or like they're having a bowel movement. So like that action, right? Take a deep breath in, hold it, and do like a crunch or like flex your abdominal muscles or like you're having a bowel movement. That's what that means. Now, on page 425, the normal sonographic appearance, you guys should know all of this. It says veins should appear anechoic. They should be easily compressed. They should show intraluminal color Doppler. So they should have color Doppler in the lumens in the center. And should be able to demonstrate a distal augmentation on a pulse wave Doppler. So when you are scanning, you should be able to augment them if they are normal. It says on pulsed Doppler, the sonographer should be able to appreciate the spontaneous flow and the respiratory phasicity. Normally, when the patient inspires, so that means takes a deep breath in, it pushes the diaphragm down or inferiorly, and it increases the intra-abdominal pressure on the IVC. The IVC collapses during inspiration. When patient expires, the pressure is relieved and venous flow can resume. If the venous valves are competent, that can also be demonstrated with pulse wave Doppler by having the patient perform a Valsalva maneuver or with the sonographer performing a proximal compression. If either technique works to cut off the Doppler signal, the valves are now considered competent. So let's talk about this because there is some new information here. So number one, veins should be anechoic is what we picked up from that. Veins should be compressible and arteries tend to not be. I mean, you can see that the arterial shape has changed because the tech was applying extrinsic transducer pressure, but the vein is what is collapsed, right? So these are normal. We're assuming there's no DVT. Veins should show intraluminal color Doppler. I think like a pet peeve for me is sometimes students don't realize like the importance of color Doppler. They think like, oh, if I show, like, I'm gonna put my box on there, but if it like doesn't light up with color, it's fine. No, it's not. You have to show it filling in with color, or else like, why are you using your color box? I mean, you can turn in a vessel with a color box and that doesn't show intraluminal color, but then you better make sure that patient has a blockage, right? Or else like fill in that color. So normal vessels should be able to show a distal augmentation. So you can see that this tech has done a distal aug. And they did one. So sometimes we do one, sometimes we do two. We used to do one where I worked two. I typically have my students do two augments. And that is like because augmenting is challenging and the more practice, the better we'll be. You can see that this tech has decided to scan the vessels retrograde, and that's okay. Remember, it can be retrograde. Also, venous flow is spontaneous. And so what that means, it's like you never really know what kind of flow you're going to get. So I want you to look at all of these flows. All of these flows are venous flows. And you can see how they all look very, very different, right? Some are more pulsatile. So like the two in the middle kind of look like arterial, right? Because they're so pulsatile. But the thing about venous flow is you'll notice there are like discrepancies. Arterial flow is very exact. Every peak will look exactly the same. Whereas like, can you guys tell how like this peak is like different than the other ones? Because it's venous flow. So if you look at the flow carefully, even though like initially when you glance at it, you're like, oh, it's arterial flow, but you'll know it's not because you'll see discrepancies like that. Also, veins should have competent valves. And so remember what valves have to do. Valves have to open and close, right? And so the way you can check for competency is something very different than what we do in the lab. So when you scan veins, you have to make sure you know why you're scanning the vein in the first place. So there's two things that we're supposed to be looking for. So number one, it would be the most common would be to check for a DVT. And that's what we do in the lab, right? So when we're scanning, like think about the protocol when we're scanning for DVT. We're scanning, we're taking pictures, and we're putting our hands distal to the transducer, right? Like below the transducer, and we're squeezing, and that's what's going to augment or change the flow, right? And we'll see those peaks. And when we see those peaks, we know that the tech has augmented, right? So I'm talking about this here. So to perform this picture, I placed my hand distal to the transducer and I gave the leg a nice squeeze, and then I saw that augmentation. So this is what you do when you're looking for a blood clot. Don't forget that we're not allowed to augment if the patient has showed a positive DVT in transverse, right? The second reason we scan veins, and this is a different, it's still a venous exam, but you're looking for a different pathology, is for valvular competency. So remember, we want veins to open and close. So the way we check that veins are closing is we force blood to go in the wrong direction for a second, so we can see if the vein closes and doesn't allow backflow. Okay, so with this one, I'm going to explain this one, and you should have them both in your pocket notebook. So in the venous section of your notebook, you should have a section that says to rule out DVT and all the information that I've talked to you guys about for doing that, the protocol, whatever. The difference is the second exam would be for valvular competency or valvular insufficiency. And this is to check if valves are working. The protocol is the same. The only difference is where you place your hand for doing the augmentation and what you're looking for as far as on the waveform, on the spectral display. What you're looking for would be different. So on the leg, okay, so this is the leg. Okay, here's the knee. So it's like just the upper portion. Okay, so there's the knee. So here's the vein in the leg. Okay. So when you're checking for valvular insufficiency, you're going to put your transducer down over the vein. So here it is in long, right? You're going to show it with color. I told you guys the protocol is the same. The only difference is where we squeeze the leg, right? And so when you're looking at the flow, right, you're going to look at your flow on your waveform, and it's just going to do like whatever it wants. Remember, venous flow is very spontaneous, so it will look different on everybody. When you take your hand, you're going to place your hand proximal to the transducer, and you're going to squeeze. And what you're going to see when you squeeze is you're going to see this initial burst of flow, so like this initial flow, and then it should stop. And then when you finally, and the reason the flow stops is because like the valves closed. So these are my closed valves, and it's not letting flow go backwards, right? So this is what this is showing. This is showing here, right here, that the flow has stopped. The flow is not going back towards the feet because the valves are closed. And then when you release your hand, you'll see the flow start going again. So like, for example, this is showing you, right? So I told you guys you're going to see that initial like increase in flow because this is the patient, this is the tech squeezing, and then it has stopped, right? And the reason it stopped is because this valve is competent. That means it's a healthy valve, right? So that means if this is the vein, that the valve's closed the valve's closed like that, right? So here's where, like if that's the vein, right? This is where your gate is. Your gate is 30 to 60 parallel or whatever, right? So your gate is up there. So you squeezed up here, you squeezed proximal to that. And so right here where your gate is, there should be no backflow. Why? Because like when you squeeze, the blood wanted to go down there, but it couldn't because the valves were closed. So then it just kind of like stood here, right, for a minute. And so the fact that you're not seeing any flow here is actually a really good sign. It's showing that the valve did what it was supposed to. And then when the tech released their hand off of the leg, then the blood kind of like shot up again towards the heart. So a lack of flow is actually how you show competent valves. So if you look at this one, right, like look, there's that initial bump that the tech when with the tech squeezing, and then look, after that the flow did not stop because these valves are incompetent, right? So like when you're looking at flow, you're looking at different things, right? When you're checking for a DVT, right? When you're looking for a DVT, so I'm going to put rule out DVT here, and here I'm going to put rule out valvular insufficiency or competence or whatever. Competence. So if the patient doesn't have a DVT, we do a distal compression or a distal augmentation with our hand. For this one, we do a proximal, right? Where are we putting our hands before the transducer? A proximal augmentation. In a normal situation, we'd see like one aug, right? And that is proving that the patient didn't have that DVT and you were able to augment the legs. For this one, you would see that initial squeeze, right? So I'm going to put like tech squeeze, just so you know, and then flow must stop. And then when you let go, you'll see like flow going back. So this is what you're looking for. You're looking for the absence of flow, and the absence of flow is what means that the valves did what they were supposed to. They closed and they like did not allow backflow. So these are two different exams. You place your hand. The protocol is the same. Your hand placement is different, right? Where are you squeezing the legs, proximal or distal, and what you're looking for on the display is different. You might have caught that this tech isn't using an angle, so they don't actually have an angle of 30 to 60. So that may seem wrong to many of us. I have always trained my students to use angles 30 to 60, no matter if they're scanning venous or arterial. You're going to meet a lot of people in the field that scan venous without an angle, and they are not wrong. You actually don't need an angle because the angle incorporation is to read velocity. And so we read the velocity of blood. Like we always care about velocity, like the speed and the direction of blood when we're talking about arteries. So in this case, we're talking about veins. We're not reading velocity. We're not telling the doctor how fast or how slow blood is moving. We're just checking if the blood is augmenting or if the blood is showing no flow when we're looking for valvular competence, right? So because we're not looking at velocity, you actually don't need to use an angle when you're scanning venous. But in my lab, I do require it because I don't want you guys to fall out of that practice. It's if you were scanning an arterial exam and you forgot to use the correct angles, or you didn't use any angle at all, your entire ultrasound is trash. Like you literally did it for nothing. Like it's like not diagnostic. The doctor would have you call that patient back in and you would be scanning them all the way through once again. Because if you can't do that with arteries, you always have to use an angle. So I know how important that is, and I don't want you guys to forget. So for me, I've always just made it a practice to scan with angles, even when we're doing venous, so we don't fall out of that practice. But you actually don't need to do it. And so you'll meet a lot of techs that don't do it. And it's because you're not reading velocity for veins, okay? Yeah, so if you guys have any questions on that section, you guys can let me know. Something else that you want to write down in your notebook as you're trying to differentiate the differences in, like, why are we scanning, the different reasons we'd be scanning veins, is so when we're looking for competent veins, we're either going to do that proximal transducer or proximal compression to the transducer, which is, I told you where to put your transducer. The other thing you can have the patient do is the Valsalva. Go ahead and take a deep breath in, hold it, and bear down like you're doing a crunch, an abdominal crunch. And both of these techniques work the same. And so when you're doing this, remember what they said about the Valsalva maneuver, it's going to dilate the vein. So in both of these examples, if you're looking at the vein will get bigger, like bigger dilation, but remember, it shouldn't show the flow on spectral display. And so both of these techniques work to stop the Doppler signal. If you can't do the proximal compression for whatever reason, you can also have the patient do the Valsalva. But like I said, I do use my patients when I really, really need to. But if I can get away with not using my patient, like I can't rely on my patient to take a deep breath. I can't say like my images are only going to be good if my patient's like fully cooperative, if my patient breathes the way I want them to breathe, if my patient turns the way I want them to turn. If they do all the things I want them to do, then my pictures are going to be good. But if they don't, my pictures are going to be bad. Like I don't do that. Like for me, it's like with the patient's help or without, like I'm still going to get my picture. And so I have just always like not been in the practice of using my patients if I don't need to, but you definitely should. If it's like the difference between turning in a good and a bad picture, then you definitely should. And I did use my patients a lot more when I was new. I think like over the years, I kind of started like letting go of that more and more. But initially, you as a new tech, you want to turn in the best pictures because you want to prove yourself, right? And so, yeah, but you can have them do the Valsalva maneuver. All right, clinical evaluation on 425. Before beginning your lower extremity venous Doppler, the sonographer should visualize the limb and make note of edema. So you want to know if the patient's leg is swollen, any varicose veins that you might see, any palpable means you can feel it. So any cord-like areas. So that just means like linear, like a line, any hard line areas that you can see. Skin pigmentation changes, so color changes, and stasis dermatitis. It says edema is a very general symptom, so it's not very specific to DVT. Edema just means swelling. A lot of people have swelling, right? Like you stand on your feet for too long. Pregnant women have swollen feet, and it doesn't necessarily mean that they have a DVT. So it's a very general, non-specific symptom. Varicose veins are also called spider veins, and those indicate venous valve insufficiency in the superficial veins. So when you see someone who has legs like this, you can make note of it that the patient has several varicose veins that are visualized. And when you touch these, they're very like soft and squishy. They're not very hard. And this does mean that the patient has incompetent valves. So it means that the patient's valves are not working right. And that's why these veins are so big, because the valves are not closing and blood is actually slipping back down. So like, remember, blood should always be, so superficial venous blood, so blood in the superficial veins is supposed to go to the deep veins, and the deep veins go to the heart. So it's actually like this path, guys. So like the superficial veins are supposed to send their blood through the perforating veins, right? So I'm going to put perf here, through the perforating veins into the deep venous system, and the deep venous system is supposed to send it to the heart. So all of these veins will have valves, right? The superficial and the deep. So the goal is to have blood like constantly moving throughout this section, throughout this system into the heart. So in this case, the blood is not going to the deep venous system as much as it should, and it goes backwards into the superficial venous system. And what do you think happens to those veins? Those veins get really big and really tortuous, and then we can see them from the outside of the skin because now they're all filled with blood, because that blood should have been pushed into the deep venous system, but it wasn't, because the valves weren't working. So the valves kind of like left the blood, leave too much blood. The valves in the superficial venous system leave too much blood in the superficial venous system, and so the veins swell up with blood, and that's why we can see them from the outside. So like when you see someone who has legs like this, I want you to think like these veins are filled with blood, and that's why they're so big, and that's why we can see them. And the reason they're filled with blood is because this blood that's in here should have gone into the deep venous system, and then from the deep venous system should have gone up towards the heart, right? But the valves weren't working. The valves in the superficial system weren't like closing and opening as they should to like push blood into the deep venous system. So a lot of blood is just like hanging out in the superficial venous system, and that's why we can see them like this from the outside of the leg. And then it says a palpable cord-like area can be indicative of a superficial thrombophlebitis. So this palpable cord-like area will be like a line, kind of what you're seeing here, and it will be harder than the rest of their skin and than the rest of their tissue. And this indicates a blood clot in the superficial vein. So again, in the superficial vein, because when you have a blood clot in the deep vein, you won't actually see this line. So this is the line is the vein. It's the superficial vein. And the reason you're seeing it is because it's superficial. The reason you're feeling the line is because it's filled with clot. So it's like, you know, swelling up that vein with clot, and the patient will feel this hard line in their leg, and they'll come in to the doctors. Stasis dermatitis is just like blood that kind of sits in one area of the leg. And what it does is it lends a brownish appearance to the leg because of like the pooling of blood. So sometimes there's like brown pigmentation in the leg. And that's just because blood is like staying or pooling in one area. That's how I remember the word stasis, because like blood is just kind of staying in the same area. The clinician may also make note if the patient has a positive Homan sign, which is when the patient performs a dorsiflexion of the ipsilateral foot and elicits a pain response. So when they take the leg that hurts and they move the toes up towards the head like that, how you see the tech pushing their toes upwards like that, that's a dorsiflex. And the patient will say, ow, that hurts. And if the patient says, ow, that hurts, it's considered a positive Homan sign. So patients can have edema, but remember that edema is not typically, it doesn't necessarily mean DVT. They can have varicose veins that you can see from the outside. They can have varicose veins that are filled with thrombus, which is called a superficial thrombophlebitis, and it'll present itself as a hard cord in the leg or a hard line. They can have stasis dermatitis, which is blood that is pooled in one section of the leg, and it will have a brownish appearance. Or they can have a positive Homan sign, which is done with the dorsiflexion of the painful leg, and it will elicit a pain response. Okay. So on page 425 under venous disease. Okay, so so far we've talked about what the different things that can go wrong in the leg that will cause leg pain. We've talked about the differences between veins and arteries. We talked about what veins should look like on ultrasound. We've talked about which veins are paired and which are not. We've talked about a clinical evaluation, which means you should be looking at the patient's leg and identifying any like abnormalities that you can visually pick out, or doing the Homan sign test to see if the patient has pain. So it says pulmonary embolism, it has a high rate of morbidity and mortality, 600,000 hospitalizations, 200,000 deaths each year. Highlight that the primary source of a pulmonary embolism is a thrombus of the deep venous system in the lower extremities. So a pulmonary emboli is a blockage in the pulmonary veins, which are in the lungs. Pulmonary emboli are very dangerous. Like usually the patient will come in with, so if you have a blockage that is in your lung, right, in the arteries or veins of your lung, the patient will not be able to breathe, right? So it's very serious, and that's why it has such a high mortality rate. Typically, when someone has a pulmonary emboli, you got to figure out where the blockage came from. So yes, the blockage is in the lung right now, and that's why the patient's in the ER, like gasping for air, right? But where did the clot come from? So typically, the clots are coming from the veins in the body. Now, people can have clots in their arms, in the veins in their arms, and those clots can go up to the lungs. Patients can have clots in their legs, and those clots can go up to the lungs. Typically, when we see a clot in the lungs, which is called the pulmonary embolism, it was a clot that was originally in the legs. So that's what he's saying. The primary symptom of DVT, the primary source of a pulmonary emboli is the thrombus that was originally in the deep venous system in the lower extremities. Now, the primary symptom of a DVT, so if the patient's like coming in with leg pain, it says painful legs, swollen legs, right? So then that's the symptoms of DVT. The symptoms are different. A symptom of a DVT, which is deep vein thrombosis, would be pain, hot, red, swollen leg, right? Patient coming in with the symptom of I can't breathe, right? The doctors are going to first treat the fact that the patient's not breathing, right? Let's look for a pulmonary embolism. But then they're going to say, well, this pulmonary embolism had to come from somewhere. Let's check the legs. Like maybe they had a DVT before, maybe they still have more DVTs in there. A lot of times, like if the DVT is in the leg and it dislodges from the vein and it shoots up to the lung, and then you scan the leg is going to be normal because the DVT is not there anymore. Where's the DVT? It's now called the pulmonary emboli because it's up in the lung, right? So you do an ultrasound of the leg will look normal. But sometimes the doctors still want us to scan the leg, even if the clot has already moved to the lung, because they may have more clot in the leg. So it says duplex sonography is accurate in determination of the presence or the absence of a venous clot. The advantage of sonography is that the better patient tolerance, accuracy, lower risk, lower cost. However, the gold standard so this is if we're looking for a DVT. Be very careful in this section, guys. They talk about pulmonary emboli and DVT like just so much that sometimes you're like, wait, is it talking about pulmonary emboli or DVT? Remember, the symptom of a pulmonary emboli will be what is the word? Struggling to breathe, right? Lacking oxygen. That's the symptom of a pulmonary emboli. The symptoms of a DVT are painful or swollen legs. They're saying you can use ultrasound because it's very advantageous to use ultrasound to check for a DVT. Did they say it's very advantageous to use ultrasound to check for a pulmonary emboli? No, because we don't scan the lungs, right? Remember, air is our enemy. So no, we're not going to scan the lungs with ultrasound. We're going to scan the legs with ultrasound. The gold standard for a pulmonary emboli to check is a pulmonary angiography. He talks about nuke med CT. You guys can skip over that. At the very bottom of that paragraph, it says when DVT in the lower extremities is the culprit, the origin often can be identified. However, highlight any vein can have a DVT, and embolization of the thrombus can occur. So not every patient with the pulmonary embolus has a positive DVT in the lower extremity. So not every single person who has a pulmonary emboli, you will find a positive DVT. Remember, because they could have had a DVT, but now it's in the lungs, so the leg is going to look totally fine, right? So you guys want to make sure you guys understand. He kind of goes back and forth so much here. Okay, at the bottom of page 425, it talks about populations that are at risk for blood clots. It says blood that does not move tends to clot. The combined factors of muscle contractions, venous valve action, so muscles contraction, valve action, and the effects of respiration propel venous blood in the extremities. Any event that immobilizes the leg. So remember, blood that doesn't move tends to clot. So events that immobilize that leg. So events like trauma, surgery, advanced age, obesity, prolonged sitting, all of these things, you know, obesity, if you just had surgery, you're probably not, you know, walking around directly after surgery. If your patient has advanced age, so is like much older, they're probably not getting enough exercise walking again. So any of these issues, trauma, surgery, advanced age, obesity, prolonged sitting, will increase the likelihood of developing a DVT. Damages, so again, these events damages the deep venous valves, increases a patient's coagulability. So not only do these, you know, situations, I should call them trauma, surgery, so on, not only do they increase a patient's coagulability, so I want you guys to separate it. I've kind of separated in my notes too. So number one, you want to know what effect may lead to blood clotting. So the first one is anything that immobilizes the leg. So in parentheses, you see what those are. A patient who has damaged venous valves. And so they give you some examples of who has damaged valves. Those people that have varicose veins. Venous insufficiency is just saying not enough blood supply, which is like the same thing. I would just know damaged venous valves. I don't think you should, it's particularly important to know what's in parentheses there. Increases a patient's coagulability. So what situations would have an increase in coagulability? So coagulability is clotting factor. So those of us that are taking oral contraceptives like birth control is known to increase the thickness of your blood, which again, clotting will increase as well. Any coagulation disorders. So some people are born naturally with thicker blood than others, higher viscosities. Recent surgeries and cancers can also increase the coagulability or the clotting factor of your blood. And also, or decrease natural flow pressure. So people who have congestive heart failure have a decrease in flow pressure. And this increases the possibility of a venous thrombosis. So in all, guys, there is an immobilized leg, number one, coagulability, number two, damaged valves, number three, and low flow pressures, number four. So there's like 4 topics, but with those 4 topics, you know, they're like, there's the information in parentheses that you want to know as well. So these are the 4 topics. And then next to these, you can write more information, right? Like what's in the parentheses, like who has decreased flow pressure, people who have congestive heart failure, you know, who is at increased risk for coagulability, damaged valves. And you're missing one, which like I would write here like an immobilized leg, you know, and then like who's not moving, who's not walking, someone who's suffered a recent trauma or surgery, or is older, is obese, or just prolonged sitting, you know, like us in school right now, we have like probably higher levels of sitting than what's typically normal for you otherwise when you're not in school, to listen to the lectures and so on. And then it says the 3 primary factors that lead to venous thrombosis is vessel damage, flow stasis, and hypercoagulability, which all 3 of them are known as Virchow's triad. So one more time, these are the factors that help propel blood. So your muscles moving help push blood towards the heart. Valves continue to help blood go towards the heart, and breathing, because venous flow depends on respiration. So respiration also helps propel blood towards the heart, right? We're talking about venous returning to the blood, to the heart. These are the events that can increase the possibility of DVT. And then these are the 3 factors that are known as Virchow's triad. So someone who has vessel damage, flow stasis, and hypercoagulability. So vessel damage, you guys obviously know what that is. Flow stasis would be flow that just tends to stay more often than it flows. Everybody has, you know, like healthy legs have flowing blood, but some of us have slower moving blood. So like flow tends to stay more, or like red blood cells tend to stay more in one spot. And so those people are at increased risk for developing a DVT, because remember, the more blood sits, the stickier it gets, and then it forms that clot because the red blood cells start to stick together and form the clot. And then just someone who has a hypercoagulability, so thicker blood, or like some sort of blood disorder, someone who's had, your book said, someone who has had a recent surgery or a cancer is known to have thicker blood. If you keep reading in that section, it says, so this section is mostly focusing on like those that are more susceptible to developing blood clots. It says, if the erythrocytes, which are the red blood cells, stagnate for too long, so they just kind of sit there for too long, natural clotting factors take effect and begin to clot or stick together. This sticky clump of erythrocytes can be seen on sonographic evaluation. So this is what it looks like on ultrasound. It looks like there is like, all of these little echoes inside of the lumen. Normally we talk about the lumen being completely anechoic, but in this case, you can see these little red blood cells. They appear to swirl, and they appear as a swirling, mobile, hypoechoic mass. So they swirl because they do move. They don't just like sit completely still. They kind of sway around inside of the lumen. So that's why they're mobile, because they are moving. And this term is called rouleau formation. Rouleau is a French term meaning coil or roll, which is how the cells begin to appear as they clump together, a roll. Rouleau formation is a precursor to thrombus. The vein fully compresses, the Doppler signal appears normal, but note should be made that the slower moving blood flow was seen. So this is something that he calls rouleau formation. Usually texts don't call it rouleau formation. We call it stasis. And so what it is, you don't have a clot. Patients that have this they're not diagnosed with a DVT or a blood clot. These are red blood cells that are moving slower. And for whatever reason, we can see these red blood cells on ultrasound, or these erythrocytes on ultrasound. You can't see it on everybody. So there are some people in the world that have red blood cells that you can see more on ultrasound than others. So like for most of us, we can't see the red blood cells. The lumen of the vessel will be completely anechoic, but there is a certain population where you can see the red blood cells and they kind of look like this. So they're hypoechoic. You will see them moving, you will see them swaying, but they so it's not a blood clot. A lot of doctors we'll write it on our worksheet. We tend to use the word stasis a lot more than rouleau formation. So we'll write it on our worksheet. And I've noticed that like a lot of radiologists don't mention it in the report. Some of them do, because they say it is a precursor of a blood clot. So this, like, if we could see a blood clot forming, this is like the first thing we would see is rouleau formation before it turns into like a real blood clot. Because at this point, it's still moving. It's just moving really slow, and the red blood cells are starting to stick together. But a lot of radiologists don't mention it because they're like, I mean, we're not going to do anything for the patient. They're not going to do anything. They're going to continue with the same, pattern of living. And it's not a DVT. It's not considered a blood clot. So like a lot of radiologists won't mention it. You guys should try to Google rouleau formation or like venous stasis ultrasound, and you guys can see really short clips of this. But yeah, so it's not like, diagnosed as a DVT, but some doctors consider a precursor to a blood clot. And then in the next section, it talks about leg pain that is not venous related. So leg pain can arise from numerous areas other than the venous system. So the leg pain can be like arterial in nature, muscular in nature. It could be a disorder with connective tissue, with nerves, trauma, infection, or skeletal, which means like the bones in your body. Next paragraph, patients with DVT may have symptoms directly related to the leg. So if you have a DVT, your symptoms might be acutely swollen leg. So that means like it hasn't been swollen for very long, leg or a painful leg. Or they may have symptoms of a pulmonary embolism, which is shortness of breath. So guys, when people come in for a DVT, they might be actually complaining about that extremity, right? That leg. Like it hurts or it's swollen. They're not really using the word red, but I've always remembered it like that, red hot swollen legs, and a hot because when you touch it, it tends to feel hotter than the other leg. But the patient may still have a DVT, even if they're coming in with shortness of breath. But at that point, the doctor may suspect that it's a pulmonary embolism that was originally a DVT in the leg. The examination consists of viewing the deep veins of the leg with B mode. So first in gray, compressing the vessels to assess for coaptation. Coaptation just means that they collapse, and documenting the changes in the spectrodoppler waveform during Valsalva maneuver or distal augmentation. So when do we do the Valsalva maneuver? When we are looking for competent valves, right? For valvular insufficiency. And then when do we do the distal augmentation? When we are looking for a DVT or a thrombus, right? So make sure that you guys keep in mind that those are different ultrasound. We're looking for different things on those ultrasounds. The patient should be positioned with the trunk slightly elevated as in the reverse Trendelenburg position. So this is an example of the reverse Trendelenburg position with the lower extremity slightly rotated outward. So I did mention to you guys earlier that the ideal position would be a 45-degree head tilt upward, and then that way that promotes like venous flow movement, and it would be easier to use your color Doppler in that case. It says some experts suggest having the patient dangle the affected leg during the examination of the calf vessels. Highlight the sonographer should start high in the groin crease, documenting the common femoral vein. And then it says the sonographer can use the saphofemoral junction at the origin of the greater saphenous vein and move superiorly to begin scanning correctly in the common femoral vein. So I do the same thing, guys. I will find the greater saphenous first. And when I find the greater saphenous, right, so you guys know it'll look like this, and it's like always like coming off of the top of the vessel. So when I find that greater saphenous vein, I know I got to slide my transducer upwards, and then the common femoral vein will be above it. If I slide my transducer down from that greater saphenous vein, I'm going to be at the superficial femoral vein or the femoral vein. And then it says the sonographer, if imaging inferior to the saphofemoral junction, the femoral vein is seen. So this is exactly what I was mentioning to you. Remember, femoral vein is also superficial femoral vein. Spectral Doppler of the vein should demonstrate phasic flow. So phasic means that the blood flow will be influenced by the patient's respiration, augmentation, and Valsalva maneuver. When moderate probe pressure is increased, so when you increase the amount of pressure with your transducer, the walls of the vein will fully coapt or collapse. Probe pressure is adequate, so how do you know you're pushing hard enough? When the artery, which is next to it, begins to deform. This maneuver must be done in transverse plane and should not be done in the longitudinal plane because it is too easy to slide off of the vessel when you are in longitudinal. So again, we do our compressions in transverse so that we don't slide off of the vessel. And we'll know we are pushing hard enough because, you know, every leg is different and some are a little bit harder to compress. We know we are compressing enough, we're adding enough extrinsic transducer pressure when the artery starts to change its shape or slightly deform. So you can see here that the artery, it looks a little different in the second half of the dual screen than it does in the first. And the vein is completely closed. And so that means this sonographer has applied enough pressure. And then if you guys keep going, it says the sonographer should begin moving inferiorly on the leg at close intervals to confirm the absence of intraluminal echogenic material. The continuation of phasic flow that varies with respiration and the coaptation of the vessel walls. So basically he's saying the sonographer should continue down the leg. So we talked about finding the greater saphenous vein and moving superiorly to find the common femoral vein, or finding the greater saphenous junction and moving inferiorly for the femoral vein. And then you're going to keep going down that leg at small intervals. So like, you know, every inch or every couple of inches, and compressing and compressing and compressing. And the reason you are compressing is because you are trying to make sure that the vessel completely collapses. If it doesn't, the patient may have a DVT. So if we look at this example here, notice that we have the right common femoral vein, and you can see that there is some echogenic material inside the lumen. And so this would be a blood clot. You could see that the tech tried. So from this picture, you could tell right where it is, right? I see the GSV up here, and then they labeled it right here that it's the common femoral vein. So this here's the common femoral vein. And you can see that even when the tech apply that compression, it says with compression, they applied that compression, but it never closed. It still remained open. So the tech should take it one step further, and you guys should write this into your notebook. What do you do when you find a DVT? Well, number one, you would measure the diameter of the original lumen, a lumen without compression, and then measure the diameter of the lumen with the compression. So you still apply the pressure. And so sometimes the measurements are the same. So for example, like if it says 0.6 and 0.6, this means that the entire lumen is filled and none of the lumen remained open. But sometimes it might say, I'm going to cross these out. Sometimes it'll say like 0.6 when you measure this one, and this one will say like 0.3. So that means like, because with the compression, the lumen got a little bit smaller, it could mean that some of the lumen was still open and it wasn't completely filled with a blood clot. The thrombus can be a completely filling thrombus or a partially filling thrombus. Like either it completely fills the lumen or partially fills the lumen. Now, this one is really obvious, but I want you guys to look at this picture here. This one also has a DVT, and it's less obvious. If you look at this picture here, you may not have thought that there was a DVT at all because the gain settings are a little bit low. So it means this image just is a little bit dark. And so, you know, you're a tech and you're scanning. Now you can see how important it is to do the compression, because maybe you wouldn't have thought that there was a DVT in that vessel. But with the compression, you can see that the vessel remained open. And so there is a DVT. And so what I would do in this case is I would increase my TGC settings at the level of the venous lumen and show the blood clot. You ideally want to show it a little bit more echogenic like this, so that the doctor believes that you found it. And this is what it looks like in long. So this is the vessel here, and I know that this is my vein because you know what this is the artery. So I love the fact that we have arteries near the veins, because I can use the artery as my guide. If I can see the artery, I know this is probably the vein, right? If this artery wasn't here, this may have been a little bit more questionable for me. Like, what is this thing? I maybe would have even ignored it. But I know that this is a vein because arteries and veins are the buddy system in the deep venous system, right? Like they always accompany each other. And so if I can use the artery to guide me to the vein. Now, the rest of that paragraph, I don't want you to read because they do explain the protocol a little bit differently than we do. But we are going to go to that last paragraph. It says the vessels that should be interrogated include the common femoral vein, the saphofemoral junction, the greater saphenous vein, the profunda, the femoral vein, the popliteal, and the popliteal trifurcation. Controversy exists regarding the value of continuing through the calf vessels. Most dedicated vascular laboratories also interrogate the anterior tibials, the posterior tibials, and the peroneals, but many radiology-based departments do not include these venous trees. So they're just saying like below the leg, right? Who is scanning that lower leg? Okay, who is scanning the trifurcation or the tibial tree? Dedicated laboratories, and maybe not just like radiology departments. In addition, when a DVT is identified, the sonographer should interrogate cephalon to document the extent of the thrombus, which may include imaging the iliac vessels. So something else that I would write in my pocket notebook. So again, you want to, like I just mentioned, when you see a vein that is not collapsible, I want you to increase the TGCs at the level of the lumen so that you could see if there truly is a DVT. Something else that I want you guys to write down in your pocket notebook is when you find a DVT in the common femoral vein, you should also scan the common iliacs, which is in the groin. So at this point, you would be in the pelvis of the patient, because you need to document how high up, like how close to the heart is the DVT. So if the DVT is here, right? And that's the first picture I took for my protocol. Isn't it only fair for the patient to, like, for me to evaluate this to see like how high up the DVT, because like this whole thing might be full of DVT. But like, yeah, if the DVT is like down here, like I don't think you need to go into the iliacs. Because I mean, you'll see, you know, above it, you've already scanned all of this. So you only have to scan the iliacs, the common iliac, when there's a DVT in the common femoral vein. Other things you want to keep in mind to be a good sonographer is you want to keep the focal zone at the level of the vessel. You want to image the vessel from an approach where the vessel is closest to the skin. So like, that's why we always scan, you know, right over the vessel. It's not like you're going to put your transducer somewhere else. Keep the vessel in the middle of the transducer or in the middle of the screen. Carefully adjust the gain so that the internal plaque, they mean the thrombus, is visualized and not blacked out by incorrect gain settings. So again, like I mentioned a minute ago, you don't want, if you're just like trying to make all your lumens completely black, you might be doing the patient a disservice, right? If they have a DVT, you got to show the DVT. So you got to brighten up that lumen with your TGCs or your gain, and then change your sonographic window if a compression cannot be completed because of a ligament, which may make that compression difficult. So we know where it may be challenging to do compressions, and that's usually at like the distal here, at the distal at the distal femoral vein, right? Because you're getting closer to the knee, and in the knee there's a lot of ligaments, and it's a lot more harder. It's a lot harder to do the compression. So they're saying, you know, you want to be mindful to not like hurt your patient either. That's why we usually use our left hand and our right hand together to squeeze this area together to assist us in doing the compression. It says the study is considered positive for DVT if the walls of the vein do not coapt when the artery has already begun to deform, or if a thrombus can be documented as echogenic material within the vein. So either of those will be the doctor would be able to diagnose or consider a positive DVT. A DVT exhibits a lack of color Doppler flow. So just like we saw in this picture here, obviously we know our color Doppler settings are correct, because like we can definitely nicely see this artery. And like at this point, the vein should also be exhibiting some color Doppler, and it doesn't. So that tells me that this lumen is completely filled with DVT, because I'm not seeing any color here. If I wasn't seeing any color in either of them, I would know that it's like a sonographer error, like I'm doing something wrong behind my machine. My gain settings are not correct, or my scale settings. But because you can see arterial flow, you know that that's probably not the case. Okay, page 427 talks about some differences between acute and chronic thrombus. So this is a picture of an acute thrombus. You'll notice that the thrombus itself is like pretty uniform in texture. It has low level echoes. That means it's more hypoechoic, and because it's more hypoechoic, it could be difficult to visualize. It's softer and a slightly more compressible. So that doesn't mean that you can compress the vein fully. It just means it's more compressible than in relation to like a chronic DVT. It says that it's poorly attached to the wall, and sometimes you'll see it kind of like flap around within the vessel. I mean, it is attached to the wall. Let's not get that confused. It is a true DVT. It is not gonna, you're not gonna be able to fully collapse the vein, and it is attached to the wall. It's just more loosely attached. So it's, I kind of picture like jello, like it's kind of like, it kind of like shakes around and stuff. But I mean, it's still, it's still a DVT. And then it distends the vessel. And that's why you can see that this vessel is like so large in diameter. For this one, you can see this like open part of the vessel here where there is no DVT. So this would actually be considered like a partial DVT. If it would, so would you call this a complete or a partial? I would call it a partial because there is still like a small opening here where there is no DVT, but I'm not talking about a partial or complete. I'm just telling you that this is an acute one. And again, I think of like a jello when I think about acute DVT. A chronic DVT is a lot different than this one. So this is what a chronic looks like. And it is already, you can tell that it's a lot harder to visualize because the vessel is smaller in diameter. So it says it's heterogeneous. So when you look at the DVT, like you'll see like really bright spots, like some really dark spots. So it's kind of like mixed in echogenicity. It does not compress at all. It is like rigidly attached. So it's like really, really hard, and it contracts the vessel, and it makes the vessel look more tortuous. So like, if you remember this one looked like more like a straight vessel. Whereas if you follow this one, it like goes up a little bit and then it comes down and then it goes up. So it is definitely more tortuous or bent or kinked or however you want to call it. Risk factors, again, are any trauma, any reason for immobility or paralysis. That means like the patient is paralyzed and can't move about freely. If they had a history of prior DVT, if they had a recent major surgery. And again, don't forget that surgery not only makes your blood thicker, but also surgery leads to lack of movement, right? So blood that doesn't move tends to clot. Cancers and chemotherapy, again, not only are you probably not active during times of chemotherapy, but you are also known to have some thicker blood. A family history, a congestive heart failure, pregnancy. Again, pregnancy just because of like the lack of movement. Oral contraceptives that thicken your blood, any hypercoagulability issues, so like high clotting factors, and prolonged bed rest.